Hey everyone, floating ventilator guys back. So just going to go over the post I yesterday. So this is essentially how I found the patient. Now, remember, when I approach significant asynchrony, I tend to try to visualize what the breath should look like and then what it actually looks like. So what it should look like is what I drew in red. So in the pressure tracing, sort of a brisk upstroke, the submorphology, which could either be a straight line or a tombstone, stressing and volume control, and then the end inspiration, the vent depressurizes, you go back down the PEEP. But what we see here is not that. So what you see here is that on inspiration, that pressure tracing gets pulled way inward. So the difference between the red and the orange is what I have shaded in blue. And what we have shaded in blue is essentially the work that the patient is doing. So if we dropped an esophageal balloon, what we would see is a significant amount of work and a significant amount of pressure being generated by the patient, which then becomes the patient's work of breathing, which then defeats the whole purpose of the patient being on the ventilator if the patient has a high work of breathing on the ventilator. Now we think that the patient has a high work of breathing because there's probably a lot of auto PEEP. So remember, there's a couple cardinal signs of auto PEEP this patient's displaying: difference in area under the curves, the flow is returning to the baseline, and also there was some ineffective trigger, although I don't have it here. So the other thing we can see in this tracing is that even though the patient is triggering each breath, you can imagine that that orange line starts to dip downward sort of even before the vent fires. So it starts to dip down, I think, somewhere where the green line is. So what we call that is sort of a delay trigger. Now, there could be delay trigger for a lot of reasons, but one of those reasons could be auto PEEP. Patients with COPD and emphysema, remember, have a high dead space fraction. So because there's a high dead space fraction, they need a higher overall minute ventilation to maintain a sort of a normal PCO2 and pH. So while we have the patient locked in at 450, the patient's minute ventilation is going to be high because they're a smaller tidal volume with the certain minute ventilation requirement they have because of their dead space by breathing faster. And we know that patients with obstructive lung disease, as they breathe faster, there's a higher chance for auto PEEP. So in the pressure control breaths that we'll talk about next, you will notice that the minute ventilation is about the same, but the rate is slower. So full disclosure, I switched the patient to pressure control because I wanted to see if what the patient would do if they had a little bit more freedom over their breath. So almost immediately when I switched the patient from volume control to pressure control, this is what the patient was doing. So what you'll notice sort of is immediately that the rate has gone down significantly. Now some of these breaths are controlled breaths, but there are some spontaneous breaths sort of mixed in. So what you notice is that obviously the total volume has gone up quite high, right, into the 700s, which for this patient represented somewhere in 9 ml per kg realm. Their respiratory rate slowed down significantly from 30 to 15, and because their total volume went up, they're able to maintain a similar minute ventilation. Now remember, from the goals of ventilation, we want to have a plateau pressure less than 30, a pH of around 7.2, and no to minimal auto PEEP. In the volume control breaths, we probably were breaking at least two of those goals. There was auto PEEP, and because of the auto PEEP was probably contributing significantly to the plateau pressure. Now in this situation, what is the plateau pressure? I'll tell you that I measured it and it was in the 20s, but we know that it's in the 20s because even on these controlled breaths that I think are maybe not totally passive, but pretty close to passive, you notice that at end inspiration, you're not at a flow of zero, right? Meaning that the alveolar pressure, since there's still flow, there's probably still a pressure gradient, meaning the alveolar pressure has to be less than our set or peak airway pressure. And these, have these blue lines drawn down. They may or may not signify ineffective trigger, which could also signify auto PEEP. And I think that because I took this right after the patient was switched to volume control and pressure control, there probably still was auto PEEP remaining. The most important was that on volume control, the patient was agitated, needed more and more sedation. On pressure control, the patient was much more comfortable and we were actually able to come down on sedation. So I think proof is that volume control settings were much more uncomfortable for the patient, probably because there was auto PEEP. Lastly, when we think about how the flow curve should look in pressure control, and the reason I can say that the alveolar pressure is probably less than 22 because there's still a pressure gradient, because at end inspiration, there's still gradient here because the flow hasn't gone to zero, is because in pressure control, you remember that if the patient is paralyzed or passive, what it should look like is sort of this natural decay based on the resistance and compliance. When you have a high amount of flow starvation and pressure control, that flow curve gets kicked out into the yellow. And I'm not really seeing that here, even though it doesn't look perfect.